Hello.
I'm Tia,
Emery.
and we did our presentation on interventions for patients with osteitis pubis or athletic pubalgia.
So some objectives we're going to learn. Students will review the definition of osteitis pubis / athletic pubalgia. Students will discuss 3 problems associated with the condition. Students will identify supporting interventions to solve the problem. So just getting into a review. This condition, or athletic pubalgia, is a condition where pain stems from the structures attached to the pubic bone specifically. And osteitis pubis is just an inflammatory condition caused by overuse of the pubic symphysis and adjacent ischiorami. This condition is often seen in athletes participating in multi-directional activities such as running, gymnastics, basketball, rugby, and tennis. There are 4 stages in this condition. Stage 1 refers to pain located in the unilateral kicking leg and pain that worsens after training. Stage 2 is characterized by bilateral inguinal pain that worsens after training. Stage 3 is characterized by bilateral inguinal and lower abdominal pain that worsens with multidirectional movements. And stage 4 is characterized by bilateral inguinal, lower abdominal, and low back pain that worsens with things such as sneezing, defecation, walking, and prevents individuals from performing just normal ADOs. And this condition is more common in men, as since we participate in a lot of high intensity sports, it causes a lot of twisting and pulling on the pelvic region.
So one of the deficits that people may experience is decreased hip range of motion. So in the maximum perfection phase, we can do a lateral distraction of the hip. We could do, I'm not going to do it because we don't have to do it. And then we could do marching, and then we could also do side lying abduction and adduction. And then for the moderate phase, we can do long sitting leg lifts over the cone, which you want to do that one. Just have him long sitting. And then have him lift his leg up and over, not that one, the other one. Yeah, up and over the cone. And then he also has to contract his abdominal muscles to remain erect. And then this side too. While simultaneously contracting his iliopsoas along with his abductors and adductors. And then we can also do standing hip extension in the moderate phase, and we can make it tougher by having a cuff weight around his ankle. And then for the minimum phase, we can do skiing, which is just having one leg out, come back, another leg out, and come back. And then we could increase difficulty by having him go fully horizontal, I guess, full flexion, or adding a cuff weight. And then we can do star excursion, which will just stay in the middle, go to the side, go out. Ah, oh no. Yeah. You can also go diagonally. Really go, yeah. But don't touch the ground, just go back and come forward. Back. Also work some stability while increasing range of motion. Then, yeah. And then also decrease core stabilization due to overworked abdominal muscles. So to help this deficit in the maximum perfection phase, we can do abdominal half sit-ups where they just do a sit-up and their fingers reach their knees instead of doing the whole sit-up. And then we can also do a posterior pelvic tilt into the mat. And then for the moderate phase, we could do dead bugs and a plank. And then for a minimum, we could do leg push downs, which is just the ones where, okay, so kick your feet up to the knee and then have them control on the way down, really contracting those slow on the way down. So slow it down. Great. And then we'll do, thank you, a low lift plank. So if you'll get on your elbows. And scalp to a plank. Then touch my hand. This one, other leg. Good. Great. It's back and forth.
Alright, then we have altered posture. So for the maximum protection phase, could incorporate some soft tissue mobilization of the hip flexors and hip external rotators. So we've seen these techniques. So we have the piriformis release, and we also have the psoas release. Then we could also incorporate some passive hip flexion and hip extension.
Oh.
So we can incorporate both these techniques as they're important for maintaining mobility without exacerbating any sort of extra unnecessary pain. So for the moderate protection phase, we can incorporate things such as adductor isometrics and also some anterior and posterior pelvic tilts. So for the adductor isometrics, could have something like a pillow, kind of put it in between the patient's legs here, have them squeeze the pillow as tight as they can. Okay.
Yeah.
Have them squeeze as tight as they can. This is great for engaging the pelvic muscles, engaging the core. And for the anterior and posterior pelvic tilts, this is great to engage the abdominal muscles while also still creating that pelvic involvement. So if I slide my hand under your back, can I have you push it to my hand? Good. Push out. Push in. Push out. Then for the minimum protection phase, you can incorporate things such as standing trunk rotations and medicine ball throws. These are great to help retrain the pelvis and help the core function as a unit. And they're also great to restore core strength, hip stability, improve coordination, and rotation power. So for the standing trunk rotations, I'm just gonna take the ball, just rotate side to side. Then for the medicine ball throws, you could face me. It's going to get down almost a full squat, explode up, and then pass the ball. And this is great because it involves multiple muscle groups while also keeping everything contained and keeping the hips stable also. These are our references. Are there any questions?
This is probably common sense, I don't know. But whenever you're doing the one where they're like, I forgot the name, and he's like having lift his leg up, each one and look to your hand. Does it, since you're working on the core, like he was kind of leaned back, but we want them to be sitting up straight since it's to help out the core muscles, or would them slightly leaning back to be comfortable? How would you accommodate for?
I would.
If they turn lean back?
I think it'd be ideal to have them sit up straight. What I was thinking is that you could be behind the patient if they do lean back, but I would need a buddy or a technician body.
So tables will also shift up that line too.
Yeah.
How about those shoes? that you have these tools in your toolbox. You have them if you need them. And again, if I had felt the need, and I try to avoid it when I don't have to, but if I felt the need to have to assess that pubic symphysis region on a male, the other thing is I will, again, very much so, show them in the book, on the skeleton, I'll show them, I will ask them, I'll say, can you feel right here, on this bone right here, is it tender? I'll ask them to palpate themselves. Or a female who's not comfortable with me getting there. Anybody who's not comfortable, sometimes I'll ask them, is it tender? And the other thing is just, again, anybody who's got some tissue there that might be, well, I'll just say, this is where I'm trying to get. So if you can just shift things so that we can get to this region, but it's still very accessible for those patients who